Okay, we're going to go ahead and start here. It says it's unable to start the recording, but when I close it, it acts like it has been recording. So I don't know what's happening. So I'm just going to start. We got to go. So we'll see if it works or not. So we're going to move on here and talk about neoplasia. Some objectives here to differentiate between benign and malignant tumors. Look at the origins of cancer, what those various origins are. Look at abnormal cell signaling, which is a big part of cancer that we're learning more about these days, and it's driving treatment decisions. Look at the genetics of cancer, look at grading scales and differentiate grading from staging. Look at some common manifestations of cancer, and then look at treatments. So just to define some terms, neoplasia, means new growth. Technically, it doesn't mean cancer. Now, that word neoplasia has come to become equivalent to cancer. But really, a benign tumor is also a neoplasia. A wart is a neoplasia. Callus is a neoplasia. Well, it may not be new growth, but so it doesn't have to necessarily mean cancer, but it has come to mean that. So when people hear the word neoplasia, that's always what they think is cancer. A tumor is just a growth accumulation of tissue, and again, it can be benign or malignant, and then we're going to differentiate those two terms in terms of characteristics to see what makes something a benign tumor and what makes it a malignant tumor. And then metastasis is spread to distant sites. So it's not just the local invasion as the tumor expands, but it's moving away from that local area. So malignant neoplasia is what cancer technically is, malignant neoplasia, and it's uncontrolled growth of cells. Now in normal cells, you only get new growth of cells when there's room there. And so as other cells die off, new cells form, and you don't get more cells than there's space for. Normal cells only reproduce when they get the appropriate signals to do so. They have to be instructed to replicate. They don't just do that automatically. And we talked about apoptosis the first week. If they get a signal, if normal cells get an apoptosis signal, they kill themselves. They commit cell suicide. They die. So that's normal features. Now, just looking at tumors themselves and looking at some differentiation. So benign tumors tend to remain localized. They're kind of circumscribed. They're easier to remove surgically because they're kind of, it's almost like there's a boundary around them, where malignant cells spread to distant sites and also kind of stick fingers out into the localized tissue. They're invasive. Benign tumors tend to be slower growing, although there are rapidly growing tumors, benign tumors, and malignant cells tend to be more rapidly growing. Now, a benign tumor, even if it's slow growing, if it's in a specific location, it can kill you. So just because it's called benign doesn't mean that it's not dangerous. So if you have a benign tumor in your brain, it can kill you, even though it's got benign in its name. And then a key feature in terms of looking at a cell under the microscope is whether it's well differentiated or what's called anaplastic. Now, when we think back to the stem cell slides that we looked at last week, where there's a stem cell at the beginning and then the cell develops and matures, it becomes more differentiated. Okay? It changes from its stem cell to its specific cell. That means it's differentiated. When cancer cells replicate, they replicate so fast and so often that they lose their differentiation. They don't look so much like the cells that they originated from. So if you have a liver tumor, for example, they're going to look less and less and less like their specialized liver cells like they're supposed to look. Now we can still tell where they came from, but they're not very differentiated, and that's called anaplasia. We say that they're anaplastic. So malignant cells grow even when there is no signal to grow. They reproduce themselves at will. They don't wait for some signal to come and tell them to reproduce. And they do that in an unlimited fashion. Nothing stops them. They continue to reproduce, and they don't respond to apoptosis signals. So even though the cell DNA is damaged, which should trigger apoptosis, the cell doesn't kill itself. It continues to replicate with its damaged DNA. They become more undifferentiated or develop anaplasia, and they leave where they started and go somewhere else. And of course, what's interesting about that is if you have a bone tumor, for example, we can tell, did it come from the lung or did it come from the breast or where did it come from? If you have a tumor in your brain, is it an original site or did it come from somewhere else? So it's interesting that we can identify that even when they've moved away. So again, just a diagram that shows the same kind of thing. So cancer has a large number of dividing cells. The nuclei change. They become large and variably shaped. And because the nucleus is large, there's not as much cytoplasm around the nucleus. The cells vary in size and shape instead of being fairly uniform. They lose their specialized features. That's the anaplasia. They get disorganized arrangements, and they have a poorly defined boundary around them. Now, when we look at causes of cancer, there are a number of causes that we'll look at. One is inheritance. There are some cancers that are inherited. You inherit the genes for those. Now, if there's a mutation in somatic cells, then there is no inheritance in future generations. The person develops that as an adult in a somatic cell. It's not passed on. But if the mutation is in germline cells, then it can be passed on from generation to generation. And there are a number of conditions that are malignancies in various tissues. These are the tissues that they're in. So Wilms tumor is one. That's a tumor of the kidney. That's an inherited genetic tumor that's where the genetic material is passed to the kids. Familial adenomatous polyposis, that's where you get colon polyps, but you tend to get them at a very young age, and we'll talk about this later when we talk about GI, but those are people that often have colectomies, have their colon removed when they're 20 because of the risk of colon cancer is so high. Then we look to the environment and see that there are environmental contributors to cancer as well. An interaction probably between a genetic issue and also an environmental issue. Genes are going to play a role in every kind of cancer, whether it's a direct inheritance or whether it's mutations of other genes that lead to cancer. So we know that there are environmental agents that if we're exposed to them can increase the risk of cancer. And one of the ways we know that it's an environmental issue is that the incidence is variable around the world. So if you don't have that exposure, you don't get that kind of cancer. So here are all kinds of carcinogens that are in the environment and some occupations where those are often encountered. And so we know that there are people at risk because of their occupation for malignancies and then the types of cancer that you develop. Infection is associated with development of cancer, and about 15% of cancers worldwide are related to infection, and more so in developing nations than in well-developed or industrialized nations. And there's viruses that cause cancer, and there's two major groups. This is extra for you. It's not a major detail, but just different kinds of viruses, DNA or RNA viruses. And here's that Epstein-Barr virus again. We mentioned that earlier. So that is associated with a particular type of cancer called Burkitt's lymphoma. Now, we don't necessarily see that someone, for example, that's had mononucleosis goes on to develop lymphoma at a higher rate, but it's the same organism that's involved there, can be involved there. Human papillomavirus, we know that that accounts for most cases of cervical cancer. Now, it doesn't account for 100%. So what we have to be sure and let people know is that if they're not sexually active, if women are not sexually active, and so they don't think they're at risk for HPV, they still have to have pap smears because there are some other cases of cervical cancer. A couple of things can happen where viruses lead to cancer. One is the virus itself can cause mutations that lead to cancerous changes in the cells. And then as the cells divide, that increases the risk of spontaneous mutation. And then another mechanism is that the immune system can be compromised, so it's busy fighting the virus, and so it's not fighting malignant cells that might be in the body. So there's a theory that we all have malignant cells in us, and it's just that our immune system is protecting us against those by destroying them on a regular basis, which is their job. One of the main functions of the immune system is surveillance, to be out looking for abnormalities and getting rid of them. So if the immune system is busy fighting this virus, then maybe they're missing some of those malignant cells that just happen to be in you, waiting for an opportunity to multiply. Bacteria, Helicobacter pylori, what's that associated with? Ulcers. About 50% of the world's population is infected with Helicobacter, and it's the most common cause of gastric infection, peptic ulcer disease, but also gastric lymphomas and gastric carcinomas. So it can cause cancer as well. So we've looked at genes, environment, viruses and bacteria. Another cause of cancer is acquired mutations. And this is changes in our DNA structure, and we accumulate these mutations over time. We probably accumulate hundreds of mutations in our lifetime. Some of them may lead to cancer, some of them may not. But that's one of the reasons that we have increased incidence of cancer as we age, is because we're accumulating those mutations as we go along. What we're going to look at fairly deeply is pro-growth and anti-growth control mechanisms and how mutations in those genes lead to cancer. So there are all kinds of genes associated with cancer, and I don't expect that you are going to memorize this or where these are, but here's, for example, BRCA1 that we talked about briefly last week. Here's a cell cycle and apoptosis regulator gene, P53, so if it's mutated, we have problems with that. Transcription genes, another apoptosis gene. Growth factors, growth inhibitor factors, and growth factor receptors, PDGF, EGF, we're going to talk about those a little bit. So just all kinds of genes that are regulating all the communication that happens in the cell, and how when that's abnormal, it can lead to cancer. Specifically that growth signaling, sending the signals that say to this cell, you should grow or you should not grow. Abnormalities there are a big issue. So we have some kind of stimulus that causes a genetic mutation in either oncogenes or tumor suppressor genes, and we'll define those. So our normal cells are affected, and then that transforms a cell, and then those cells proliferate. So it's stages that we're going through, and we're going to look at, medicine is going to look at each of those areas to see at what point can we stop this cycle and interfere. So the two categories of genes that are very important here are proto-oncogenes and tumor suppressor genes. Now we all have those genes. We all have proto-oncogenes. Those are normal genes that regulate growth. They're normal genes. We all have proto-oncogenes. When they mutate, then we call them oncogenes, and then they're cancer-causing genes.
So they're called proto-oncogenes until they mutate.
Right. Mm-hmm. Yep. So proto-oncogenes regulate all of our growth factors, our growth factor receptors, our signaling systems in our body. So when we have, say you have surgery and have an incision, and then the incision needs to heal, proto-oncogenes are going to regulate that. That's a normal time when you need more cell growth, right? So that's a normal thing. So we can have problems. This slide just shows the various steps along the way where we could have problems. So the first step is the growth factor. So normal cells, as we said, don't stimulate their own cell division. They wait until they get signals from growth factor to replicate. But if there's a mutation in those growth factor genes, then those cells can replicate in an unlimited way and grow into a tumor. We also can get autocrine signaling. We mentioned that a week or two ago. That's just the cell stimulating itself to replicate. It's just stimulating itself. So these are some normal proto-oncogenes: PDGF, platelet-derived growth factor; EGF, epidermal-derived growth or epidermal growth factor. Those are normal growth factors that we all have. If we get mutations in the genes that regulate those, we can get, with PDGF, we can get a brain tumor, glioma. With EGF, we can get a breast malignancy. then growth factor has to enter the cell some way. And so we have growth factor circulating out in the environment, but to get into the cell, it's got to go through a receptor. So then we have genes that regulate the receptors. So we might get receptors that shouldn't be there. We might get receptors that are more sensitive to the growth factor that's around. All kinds of things that can happen that if there's a problem with those genes that regulate the receptors can lead to excessive growth. So HER2 is human epidermal receptor 2. That's a proto-oncogene that when it's mutated, it also is associated with breast cancer. RET is another one that's associated with thyroid. So what do you know about HER2? Anybody know about a drug that's related to that? Herceptin. Herceptin is a drug that's targeted to making this HER2, blocking this HER2 so we don't have too many growth receptors on the cells. Okay? And that's true for all of these. Drugs are being targeted to all of these abnormalities in these growth factors, receptors, and signaling mechanisms. Then once the growth factor gets in through the receptor and into the cell, then we have cytoplasmic signaling pathways passing the message through the cytoplasm and then ultimately into the DNA. So here we can get activation of these intracellular pathways without growth factor ever coming through the receptor. It's just going to be activated on its own without a stimulus from the outside. Or we can have where the signal should be stopped, where it should be broken down, that can be prevented by a mutation in these genes. So RAS is a gene that's implicated in a lot of types of cancer. About 30% of all cancers have a mutation of the RAS gene. And then ABL is associated with leukemia, and we'll talk about that when we get to hematologic. And then finally, so the growth factors out in the environment are one, the receptors are the second pathway, the cytoplasmic intracellular signaling is third, and then inside the DNA we have our transcription factors. So that's the fourth place that we can have some problem. So here we can have too much production of things that stimulate transcription or inhibition of things that should turn it off. Either way, we're going to have excessive cell growth. Excessive cell replication. So here are some examples. Here, MYC, there's a C, MYC, and NYC, and they cause different kinds of cancers when there's a mutation in those genes. Now, there's a lot of theories about how proto-oncogenes get transmitted or transformed into oncogenes. One is that a virus might do that, a retrovirus. And we see that already because that's how Kaposi sarcoma happens. A retrovirus gets into the body and translates and causes Kaposi sarcoma to be able to take hold there. And that's the same thing with the Epstein-Barr and Burkitt's lymphoma and another kind of cancer that occurs. So we think that retrovirus gets in, causes a mutation of the proto-oncogene that ultimately leads to the development of cancer. So that's the growth side of it. That's the proto-oncogenes turning into oncogenes. Our normal proto-oncogenes that we all have are balanced by tumor suppressor genes. Now they got that name because they were discovered when they were looking at cancer, but they're normal things that we all have, tumor suppressor genes to suppress growth. When we don't want excessive growth, we want to turn it off normally, it's still called the tumor suppressor gene. So there's two major ones, the RB gene and the P53 gene. And the P53 one is often called the suicide gene. It's the one that does a lot of the regulation of apoptosis. There are other genes involved in that too, but P53 was the big one that we discovered first. So mutations of these genes and others that we're not naming can lead to a variety of cancers. And the mutation of P53 is implicated in 50% of all tumors. So it's a very active area of research that we're looking at. Interestingly enough, this last one here, MTS1, is also implicated in cardiac disease. So they're looking at what's the relationship between malignancy and various kinds of cardiac disease. So that's an area of research. So P53, normally what happens is when your cells are damaged, that P53 stimulates apoptosis so that the cell dies, so that it can't replicate. If it's damaged, we don't want it to replicate. So it either slows down replication so that it has a time to repair itself, or it triggers cell suicide so that that damaged cell doesn't replicate. That's the normal function of it. So in cancer, if that normal function doesn't happen, the cell just continues to replicate even though the DNA is damaged, and then we get multiplication of those abnormalities. And one of the ways that chemotherapy and radiation work is to damage cells to trigger apoptosis, so that the cells will kill themselves. That's the goal. Okay? In the meantime, it also kills other cells as well. But that's one of the mechanisms that we're looking for in chemotherapy and radiation both. So BRCA1 and 2, we mentioned this a little bit last week, but they're normal genes that we have that normally suppress breast cancer. And when there's mutations in those genes, it increases the risk of both breast cancer and ovarian cancer. But again, this was that penetrance that we talked about. It's 85% risk of breast cancer, not 100%. Just because you have the gene doesn't automatically mean you're going to get breast cancer, but the odds are pretty high. So metastasis is spread of the malignancy to other parts of the body, and that can be through the bloodstream, through the lymph nodes. But we can still identify the original site of the tumor, where it came from.
Is that just by the recognition of the cells?
Yes, we can identify the cell qualities and characteristics and so on. Even though there's anaplasia, we can still tell where it came from. Yeah. And so that's called grading. That's looking at the degree of differentiation that's still there. And so a tumor that's more anaplastic or less well differentiated, those are synonyms. More anaplastic is the same as less differentiated. Okay, that's the worst kind of cancer. So the less anaplasia there is, the more differentiation it is, the lower the grade of tumor, and the better prognosis there will be. Graham? Oh, okay.
So they'll call it like metastases with the primary of unknown origin.
Okay, good. So there does come a place or a point where it's so undifferentiated that you can't recognize the original site anymore. Thank you. Okay, so that's the grading piece of it. And histological means just the cellular characteristics. So it's looking at the cells under a microscope. Staging is trying to determine how widespread the tumor is in your body. And I always had a hard time keeping these straight until I had a student tell me a few years ago that when you think about staging, like being on stage, if you're an actor, and they talk about upstage and downstage and stage right and stage left, it's where you are on the stage. So staging is where it is in the body. It's the location piece of it. Okay? And there are various systems used to track tumors and how extensive they are. But one system that's used is the TNM system. So the T is tumor, whether it's local or invasive. The N is nodes, if lymph nodes are involved or not, and the M is metastasis. And you see various scales of this being used. So this is one, although I think the system that your book talks about only goes up to T2. Is that right? Something's different about it. Anyway, so there's, depending on the type of cancer that you're looking at, there's different grading systems. And then there's also where you see stage 1, stage 2, stage 3, stage 4. That also is used depending on the kind of cancer. So with these, the higher the number, the more extensive it is. So for lymph nodes, only the lymph nodes that drain the area of the primary tumor are looked at or considered in this scheme. And, it's the N that the book only goes to 2, but there are some scales that you'll see where they go up to N4, so more lymph node involvement. And then metastasis is just either 0 or 1. It either either have metastasis or you don't. But one thing to remember is that even when we can't see metastasis, there still can be micrometastasis where cells have broken off and spread already to the other parts of the body. So here's just some examples, and again, just the higher the number, the more extensive the tumor is. The larger the tumor is, the more likely it's spread to other places. So lots of tests to do to figure out if there's metastasis, scans and CT, MRIs, using antibodies and injecting that into the body with a radioactive isotope to go to the tumor sites and show up. I don't know if I have it. I don't think I have it on here. There to look at like a bone scan or something to see where the metastasis is. So regardless of the type of cancer, these are the common responses that we see. Let me just see what I've got here. So just to look at some of the mechanisms of these. So pain happens for all kinds of reasons. It could be tumor pressing on tissue, pressing on nerves. Could be inflammatory response, stimulating some of those prostaglandins that we talked about last week, which are pain mediators. Certainly fear and fatigue accentuate pain, and if you have cancer, you certainly have those things as well. And then treatments that we do for patients can make that worse. Stomatitis that happens with radiation therapy and chemotherapy, that's painful. So the treatments we're doing may compound that. Cachexia, that's that wasting away that happens. We think that tumor cells suck nutrients away from the normal cells, and so your body tissues waste away while the cancer grows and multiplies. If you have stomatitis, you're not going to feel like eating much. If you're nauseated from chemotherapy, you're not going to feel like eating much. So all kinds of reasons to have cachexia.
Well, there's also, in treatment and stuff, it changes your taste buds, and so everything can taste like dirt.
Yep. Yep.
Or something else.
Yeah, taste changes. Then people with malignancies often have immune system suppression. That can be from the treatments that we use, because we use treatments to suppress the immune system, like chemotherapy and radiation. But we're finding that cancer cells actually secrete substances that suppress your immune system. So the cancer cells themselves are doing that. You may have a reduction in your T and B cells, so that suppresses your immune system. Bone marrow suppression from nutrition and drugs and so on. Now, remember that the bone marrow is the source of 3 different types of blood cells. So anemia is the red blood cells, leukopenia or low white blood cell count, suppression of the white blood cells, and thrombocytopenia, the platelets. So all 3, if you've got one, you've probably got the others too, whether we see them yet or whether they're manifesting, whether they're causing other problems. And then infection is a major cause of illness and death in people with cancer. Because of the suppressed immune system, they're just not able to fight infection as well. They're at high risk for infections. We often talk about isolating patients so that they're not exposed to infections. Their infections often are difficult to treat because their immune system isn't working very well. So surgery is one treatment for cancer. The earlier it is, the better. The more localized it is, the better. Often, as part of surgery, doing lymph node biopsies to help determine the staging of the cancer. And again, people may have undetectable metastases, which is why we often see chemotherapy and radiation even after surgery. We think we got everything, but just in case, we want to make sure that we wipe out whatever cells might be hiding out there. Radiation, again, we talked about this, damaging the cells to trigger apoptosis to happen. And cancers that are resistant to radiation, we think are not responding to that apoptosis signal. Chemotherapy, all kinds of different chemotherapy medications targeting cell replication and other aspects of growth and development of the cancer. Angiogenesis inhibitors, this is one area of newer research. If your body is creating tumors, those tumors need a blood supply. And so the tumor itself is triggering growth of new blood vessels. So we've developed inhibitors to inhibit that new blood vessel growth. We've had some success with that. We're continuing to look at that. Other kinds of treatments, biologic response modifiers, these are really the drugs that are going to support the immune system and make it work better. Interferons and interleukins both are being used, and there's some that have been approved, FDA approved, for various kinds of cancer. I can't remember if it's interleukin or interferon that's been approved for Kaposi sarcoma, for example, but there's a number of those immune modulators that have been FDA approved. Monoclonal antibodies to deliver drugs to cancer sites, to just carry the drug into the cell for us and get to the cancer location. And all of the monoclonal antibodies, the names of them end in MAB. So, for example, gemtuzumab, not a good pronunciator on that one. You know that that's an antibody that we're delivering to the patient for treatment. So gene therapy, we're looking at all of those clinical trials that we looked at last week. So many of them related to cancer treatment, finding cancer treatments, and a lot of them are targeted towards these particular genes, either suppressing oncogenes or supplementing tumor suppressor genes so that they can do their job and prevent this excessive cell growth. These are just a few of drugs that have been approved probably in the last 5 or 10 years, targeted specifically to these either oncogenes or tumor suppressor genes or other of those cell cycling, cell communication areas in the cell. So Gleevec is one of them, and one of those genes that can be abnormal is the ABL. It's a normal proto-oncogene that's used for signal transduction, that cellular communication. In chronic myelogenous leukemia, there's something called Philadelphia chromosome, where there's transposition of genetic material, and ABL binds to BCR, which is another molecule that has to do with communication, cellular communication. And that causes abnormal communication. When those two are bound together, when the ABL and the BCR are bound together, you have abnormal cell communication. And what Gleevec does is it inhibits that enzyme that's produced by that binding so that that abnormal cellular communication doesn't happen. So it inhibits cell proliferation and induces apoptosis. So it triggers the cancer cell to kill itself. So that's how it interferes with tumor growth. It's used in leukemia and also in a particular kind of gastrointestinal cancer. Tarceva is one that targets the HER1 and the EGFR. Those are some of those cell signaling molecules that we looked at just a little bit ago, human epidermal receptor and epidermal growth factor receptor. When there's mutations in those, it can cause cancer, and it's associated with both lung cancer and pancreatic cancer. So Tarceva interferes with those abnormal signaling mechanisms there. Herceptin is the HER2, we mentioned that earlier, and that has to do with proto-oncogenes and is another growth factor that goes awry, becomes abnormal, and leads to breast cancer, and then this drug suppresses that. Other treatments, stem cell transplant. Graham, are you working in a stem cell transplant unit? Who? Tara? Tell us a little bit about the process and what that entails.
Well, there's different types, but with a stem cell transplant, we spend like 5 to 7 days giving them radiation and chemo to kill off their entire immune system, and then we give them the stem cells, which is like a half-hour basically blood working infusion, and then we wait for that to rescue their immune system, and that takes, depending on the type, like 7 days to 3 weeks, and during that time they have no immune system, and we just wait for their blood counts to recover, and then when they do, they're supposed to be the other person's immune system.
So we destroy the immune system of the patient, and then give them a stem cell transplant, which is like a blood transfusion essentially. And then when that takes hold in their body, the donor's immune system is now growing in the recipient's body.
And then you can get graft versus host disease, which they will use different donors depending on how much they want to kill off the remaining cancer cells.
So if you get a blood transfusion and your body attacks the blood that's been put into you, that's your immune system fighting that foreign blood that's come in. With a transplant, a stem cell transplant or a bone marrow transplant, that new immune system that's put into you attacks your body. That's graft versus host disease. So the graft that we've put into you, this transplanted material, this transplanted immune system, now attacks your body. So it's graft versus host. Good, thank you. Okay, so just some statistics about cancer, just to give you the big overview here. So about 1.5 million new cases every year, and that's all these arrows are comparisons to last year's data. So just a slight increase this year in the number of new cases, or the estimated cases for 2009 from 2008. About 12 million people worldwide with cancer. About 562,000 deaths. That's about the same as the number of people that die from heart disease every year. Heart disease is just a little bit higher than that. So it's the second leading cause of death. 5-year survival rate for all cancers, which was 50% in 1975 to 1977, overall is now 66%, but what we see are ethnic variations in care. Both in care and in response and in access to care and all of those things. Prostate cancer has the best survival rate, 98.9%. Pancreatic cancer has the worst survival rate, 5.1%, 5-year survival rate. Just some more data about African Americans. So the survival rate has increased, but it's still lower than that of Caucasian people. We also see variations in survival rates of childhood cancers. So in Europe and North America, it's about 75%. In Central America, it's the 3-year survival rate is only about 48 to 62%. This shows cancer deaths. And so lung cancer is the biggest killer of women in terms of cancer. Now, I think it's great that we have all the breast cancer research and, you know, the Susan G. Komen Foundation and all of that stuff. But that's half as many deaths each year as lung cancer. And, you know, there's all kinds of socio-political reasons for that. But lung cancer is what's killing women, not breast cancer. And then we can see the rest of I just gave you the top 5 here. And for men, lung cancer is the top in men. And then the next one is far away at 27,000, prostate cancer, much lower rate there. Now, it's interesting that if you look at the overall cancer death rate, though, it hasn't changed much over time. And that's because we're getting really good at treating some cancers, but we haven't made any progress in others, and we have new cancers that are becoming more common all the time. So here's the reduction in heart disease rates. I mean, that's huge. Decrease in cerebral vascular disease, even decrease in pneumonia and influenza. The cancer is about the same from 1950 to 2003. So breast cancer is the most common non-skin cancer in women. New cases, 192 a year. Deaths, 40,000. Lung cancer, only 103 new cases, but 70,000 of them die every year.
Chris, are you familiar with the China study?
Tell me about it.
It's a study done, and a longitudinal study done in China over decades, reporting. It also includes other countries, but basically it looks at nutrition.
Oh, uh-huh.
And the influences on our diet and how we choose our diet as how it's affected cancers.
Okay. So a China study, a longitudinal study looking at the effects of diet over decades and how that influences cancer. What's interesting is there continues to be more research coming out that suggests that diet doesn't play much of a role. Although we've had a lot of look at that, there's some newer studies that are calling that into question. So it's very interesting, at least in terms of, you know, that limiting fat and getting more nutrients and that kind of thing doesn't seem to be making any headway in terms of preventing new cancer cases. So it's interesting. I don't think the answer is there yet. And here again, and I'm focusing on women primarily because of the emphasis that breast cancer gets, and it's not, I want to put that in perspective. So heart disease, 315,000 deaths, cerebral vascular disease, 82,000 deaths, this is in women, lung cancer, 70,000. COPD, Alzheimer's disease, unintentional injuries and adverse effects kill more women than breast cancer does. Now, I mean, that's a good thing because we've got lots of treatments for breast cancer now that we didn't used to have, so it's not that I'm against treating breast cancer, it's just that it gets such press, and I think it's important to put that in perspective. I think that's it. Okay, so next week we'll come back and start with hematologic. And we'll do that hematologic case study next week, so bring that. And we'll move on to the next topics too. That won't fill our time next week, so. Yes.